It is now my pleasure to turn this call over to Regina Hawkins. Regina, please go ahead.
Thank you, Irena. Hello, everybody, and thank you for joining our CRC SimPLER, a practice workshop here this afternoon in the DC area. I hope that you're all enjoying your days after the long weekend. I know we're jumping in here pretty quickly. Annie, can you do next slide, please? Just a little to introduce myself. If we've not met yet, my name is Regina Hawkins. I'm a director for Preparedness and Radiation Readiness with the Association of State and Territorial Health Officials. I also co-lead the National Alliance for Radiation Readiness. And there's just a few bits on the screen there about what the NARR is. But the NARR is an alliance that represents public health, emergency management, and healthcare. Next slide. I'd also like to introduce you to some of the other folks that you'll see up on the screen. We've all got our cameras on here today. These are my folks that will be facilitating this ASTHO Connects with me. And we've got Annie Evans from ASTHO and Erica Green from the CDC. Next slide. Okay, and then we're going to jump right over into our presenters for today. We've got Jennifer Buzzell representing the Centers for Disease Control and Prevention that has worked as a health physicist for the Radiation Studies branch for over 20 years. Ms. Buzzell has been actively involved in analyzing and developing methods and materials to improve public health's response to radiation emergencies. This includes working with partners within CDC to strengthen the Public Health Emergency Preparedness grant capabilities, developing and exercising designs for community reception centers, and the development of tested public health risk communication messages. Additionally, she is a CDC point of contact for the National Alliance for Radiation Readiness's cooperative agreement that's between CDC and ASTHO. She holds a bachelor's degree in chemistry and a master's degree in health physics. Also joining us for today's presentation is Lauren Finklea, who is an associate service fellow for the Radiation Studies section at the Centers for Disease Control and Prevention. Ms. Finklea serves as a subject matter expert for emergency preparedness and response activities, as well as computational modeling for radiation protection. She is the lead developer and creator of CRC SimPLER. Ms. Finklea is currently the president of the Atlanta chapter of the Health Physics Society. She received her BS and MS degrees in nuclear and radiological engineering from Georgia Institute of Technology. So before we get into the actual presentations, let's go ahead and take a quick poll. We just want to get everyone warmed up and used to using the technology. Many of us have been in this virtual world now for nearly a year, so let's get our fingers stretched out a little bit and get ready to jump into some fun with the workshop. So Irena, if you could pull up those first polling questions for our participants. Perfect, great. So everyone should see just one question up on your screen to get started. And it's, are you familiar with CDC's Public Health Emergency Preparedness Grant for state and local public health departments? So if you could go ahead and click your response there. I get to cheat a little because I can see what the denominator is too as we're going through. So we're 9 of 11. So if you haven't participated yet, just a few more seconds. All right, and it looks like we are doing pretty good. We are 9-1 right now. So most familiar with the grant program, but not everybody. So we'll definitely want to keep that in mind as we jump into the next section. So let's go ahead, and I believe we have one more question before we get started. So can CDC's public health emergency preparedness funding be used for radiation preparedness activities? I feel like this might be a bit of a trick question. All right, we're just about there. We are back to the 9-1. So I guess you probably wouldn't know how the funds are going to be spent if you're not as familiar with the grant. So that completely makes sense, and we'll make sure to dabble into that a bit. So without further ado, let me go ahead and pass it over to our presenters, starting off with Jennifer Buzzell.
Thank you so much, Regina. I appreciate that introduction. And thanks to everyone for participating in our polling questions. It sounds like I don't need to dwell on this piece too much today. We have a lot of great content coming from Lauren Finklea in a few minutes. Just 2 slides. So many of you, oh, Annie, I'm not sure if you, yeah, you've got it up. Thank you so much. So many of you recognize this map of Hurricane Katrina's diaspora. Hurricane Katrina displaced over 1 million people to all parts of the nation, including Alaska, Hawaii, and Puerto Rico. Note that half relocated within a 100-mile radius of this landfall, of the landfall. This may be different in a rad nuke incident. Note that the affected population could be even larger as a result of the plume. Host communities exerted great effort to accommodate these evacuees. If this were a rad nuke incident, additional considerations for decontamination measures, either through communication, techniques like taking a shower, or in person at a community reception center, need to be taken into account for planning purposes. Next slide, please, Annie. Thank you. So to the ultimate end of being prepared for a radiation incident, the Public Health Emergency Preparedness, or PHEP, cooperative agreement is a critical source of funding for state, local, and territorial public health departments, of which many of you already are familiar with by the poll indication. So this slide shows the 15 Public Health Emergency Preparedness Cooperative Agreement capabilities. Radiation language is in each one of the capabilities, except for number 4, Emergency Public Information and Warning, which actually contains all hazard language. So it still can be used for radiation emergencies. It just doesn't specifically state radiation in the content of the language. And you can see there's the link down below volunteer management number 15 that you can go and find out more about the PHEP cooperative agreement. So thank you so much for your time, and I'm going to pass it off to Lauren Finklea.
Great, thanks, Jennifer. Give me 1 second. I'm going to start sharing my screen. Okay, so thank you everyone for joining today. So we're going to talk about CRC SimPLER, which stands for Community Reception Center Simulation Program for Leveraging and Evaluating Resources. So Annie, would you mind triggering the first poll, please? I think this is one of the previous polls. Yes. So appreciate those of you who were familiar before, but now you're not familiar. So, okay, so have you heard of CRC SimPLER before today's webinar? Okay. Okay, so looks like most of you, but not all of you. So we're going to go over what CRC SimPLER is before we go through the actual part of the workshop. So that's great. We'll kind of catch everybody up. Next poll, please. So do you have any community reception center plans? Okay, so some yeses and nos. Hopefully this tool will help you think of ways to either enhance your plans you currently have, or if you don't have plans, this will kind of help get a head start. So next poll. So have you conducted a CRC exercise? So if you guys don't have plans, then I would anticipate you probably haven't exercised. Okay. And then I believe this is the last poll. Okay, I think it's the last one. So we're going to go ahead. What is CRC SimPLER? So CRC SimPLER is a planning tool that allows for throughput calculations for radiation monitoring and decontamination, focusing at community reception centers. What's unique about this tool is that it integrates real exercise timing data from exercises we've gone to around the country. So instead of just guessing on how long something might take, we have hundreds or thousands of data points for each type of station and activity. So this gives you a more realistic view of how long something would take. And then we validated it at other exercises. We wanted it to be easy to use by public health and emergency management with no end user cost. So there's a lot of graphical outputs in this tool. We wanted to make sure it was flexible and scalable for small jurisdictions to big cities. So we wanted everyone to be able to build their CRC the way that was best for them. So the sample interface, there's 4 main components to it, and we'll open up the tool in a minute once we start walking through the scenario. But there's an input screen. So you think of how long your community reception center will be open. And for those of you who are unfamiliar with community reception centers, this is the location where after a radiation event, you would send the population to go be screened, decontaminated if needed, and then you would want to register them and then send them to the next location, whether it be a shelter, back home, to a hospital if they needed. But it's kind of a screening point to look at everyone who would be affected by the incident. So this location will say, okay, how long is the CRC going to be open each day? And then you look at the population arriving at your CRC. So depending on the incident, you would probably know how many people to anticipate arriving. Working closely with your radiation control program, you could estimate, depending on the scenario, the percent of the population that will be contaminated. This is important because that's going to directly affect how many people you need to decontaminate via showers. And then if you go to the next box, you have all of the resources used at your CRC. So you have your portal monitors, which is you walk through them and you are screened quickly. Then you have your handheld detectors before and after decon for more detailed measurements. You have your showers, and then you have registration lanes. So very, very minimum input. And then you go through your sample output summary. So it tells you some quick numbers such as, how many people you got through at the end of your shift, how much longer you would need to stay open if you were to keep this plan past the end of your shift. And then you have station breakdowns of wait times, utilization, which is the busyness of that station, and then the line length. And we'll get more into this in the actual scenario, just kind of, priming you so you're looking for things. There's an hourly breakdown. So there's a 24-hour breakdown from the start of the opening of your community reception center. And then that vertical line is the shift end. And then it goes past the shift end up to 24 hours so that you can see how things would continue to go after you shut your doors and finish processing everybody in the system. And then there's also data tables you can output. So, some people want to make their own graphs and it's more useful for them that way. So you can output all of this data into Excel files, and then you can create your own graphs and comparisons as well. So any questions before we get started in the chat? If there's anything that you had a quick question about before we go into the scenario. Okay, I don't see any. So our scenario for today, we're going to have, I'm going to read it and then, kind of keep going through. So during a playoff game at Phantom Field, it is reported that during the 7th inning, a crop duster plane flies over, misting the entirety of the arena. At first, most individuals think nothing of it, but the local emergency operations center receives a call approximately an hour later stating that surrounding radiation monitors have detected increasing levels of radiation. Stop the chat for a second. Yes, and the link to the tool, if you want to follow along, Annie put it in the chat, and then I'll bring it up on the screen as well. If you want to follow along. And for those of you who kind of want to see me go through using the tool, then you can do that as well. So you are the Community Reception Center coordinator for your jurisdiction. There's a recreation facility approximately X miles down the road from the arena you'll be using to set up your CRC. Your detection equipment is located close by, and you believe you're going to be able to notify staff to begin CRC services within 3 to 4 hours. There are neighboring counties that have CRC plans and equipment and are able to support you. The Radiation Control Program has set the screening criteria to be anyone that alarms the portal monitor will go to decon. So you'll notice we don't have a whole bunch of numbers here. And what's important is the Radiation Control Program has set the criteria, we're following it, and that's kind of how we're going to feed into the tool, because the tool doesn't look at specific numbers. It's, whatever your criteria is that you set and feel appropriate for the scenario. So again, here's the link for the tool. And Annie put that in the chat. Okay, so we're going to do a walkthrough of how to use this for the scenario for what I just gave you. I'm going to give you a sample CRC plan. And it's on purpose not going to work out well. So what we're going to do today after I show you this setup is we're going to think of how we could improve the Community Reception Center and improve our ability to process and screen and decontaminate these people. So the way that CRC SimPLER looks at flow is kind of simplified. So you have contamination screening station, which is where your portal monitor is. For those who are deemed contaminated, they go to decontamination where there are those handheld detectors and showers. And then everyone goes to registration and is discharged. So here we have the sample input screen. And I'm going to say that my shift is 8 hours. And that's about what most people seem to have that I've talked to. And you can feel free when you're playing with the tool to adjust it. We have other hours in there. We're going to estimate that we have about 2,500 people arriving at our Community Reception Center. We're going to say 50% of them are contaminated because they have some measurable amount of radiation on them. So they're going to alarm the portal and have to go to decon based off what our screening criteria was. We're going to have 2 portals, 2 handheld detectors prior to decon, 2 showers, 2 handhelds post decon or after the showers, and then we'll have 10 lanes of registration. So in the tool, you'll have these options selected, and then you would hit estimate. The summary output tab will come up like this. And you'll see that the things to note here is that we definitely aren't processing everybody. By the end of the shift, we're only getting about 860 through. And it says that we have to spend another 38 to 39 hours staying open to process everybody. And that's not acceptable or realistic. And we're going to get into some more of these numbers in a second. So I kind of highlighted areas of improvement for you to keep in mind when you're adjusting some of these parameters in the tool. So utilization is the middle graph. That is the whole graph is circled. And it's circled because almost every station besides post-handheld screening is busy the whole shift. So that means the workers aren't getting any breaks. That means that they are overworked, and there's really, even if they were operating faster, they can't really process, more people. They're at capacity. And then you have your wait times on the left graph. So you see that people waiting to get screened before they get to the shower are there for almost 3 hours. And that's a long time before you get to the shower, right? We don't want people who are contaminated to be waiting to get into the shower. And then you have an hour wait for the shower, registrations over an hour. So this is indicators as well as the line length graph on the right of these stations need additional resources or something needs to change. We can go to our 24-hour breakdown tab. So here I'm looking at contamination screening at the portal monitor and the throughput. So one thing to note here is that this station finishes processing individuals shortly after the shift end. So it might not be beneficial to add additional resources here because they're almost processing everybody in the amount of time we want it to. So now we're looking at the pre-decon handheld screening, which was the longest line and wait time when we're looking at the shift summary. So one thing to note here, this is the line length over time. It continues to rise even after the shift end and grows by more than 100 people in line. So this is a huge bottleneck, or this is what's holding up our processing speeds. We're also looking at here the registration line length. So you can see it also increases after the shift end, but after about 12 hours of operation, it starts to decrease. So maybe this isn't the biggest bottleneck, but it's still, room for improvement. And now we're looking at the Community Reception Center time at CRC. So what this is how long someone who comes to get the screening and decontamination and registration process, how long they're actually at your Community Reception Center. So, people are waiting in line longer and longer, no one's really moving. So it makes sense that after the shift, the amount of time someone's there just continues to go up. And that's not good because people are going to get restless. They might leave. They might not get the care you want. You might not be able to register them and give them information. This is also a big thing to think about. Okay, so here we have the key takeaways from what we saw. Contamination screening is not the bottleneck. There were very long lines at pre-decon screening and registration. These go up, the lines go up after the shift. It's not feasible based on the setup to finish processing everybody. And we're not going to try to stay open 39 hours after opening. So I'm not sure, let me see. Will we still be doing the breakout room with this number of people? Just double checking.
Yes, we will be breaking out into groups of 2 groups of 8.
Great. Okay, so for the breakout room, so 2 groups of 8, I want you to work together by giving solutions to this problem. So the problem is that as is, your Community Reception Center cannot screen everybody and get everybody through. So I would like that you would use the tool, change some of the parameters to kind of evaluate how improvements can be made for throughput. And then we're going to come back together with a larger group after your breakout sessions and, pick one person in your group to say what your group came to as a consensus of, we think this was the best way to change everything, and this is why we chose to do that. Keep in mind cost of resources, feasibility, how quickly you can actually get these resources. For example, if portal monitors were the big thing to get, it might not be feasible to get 20 portal monitors right now or pay for them. And then you can make choices in your assumptions for things you can do outside of the CRC that would affect how people arrive at your Community Reception Center. So think of things like communication, think of things like working with your radiation control program. So keep things in mind that there's other things you can adjust in the scenario that would impact the inputs you're putting into the tool. So, and be creative. So instructions for the breakout, find the best way to solve the issue and let us know why. And maybe things to consider, think about how you might reduce the number of people needing to be decontaminated. And specifically the resources to help improve that throughput. Okay, so I think we're ready for the breakout room. Okay, sorry, it wasn't letting me unmute. Okay, so hopefully everyone had some great discussion. Group that wasn't with me, do you want to go first? So who in your group would like to kind of report out and let us know what you did?
So I'm not sure we did great at identifying somebody to report out, Lauren.
Oh, no? Okay.
I know, horrible. Well, we were having some microphone issues. So
Okay.
I think if it's okay, I know it's sort of unorthodox, but I can definitely provide a bit of an overview. So using the EAS messaging was one of the topics of conversation. Also potentially using the like the contractor at the baseball game that sells the tickets, and you could use that post for contact tracing type work, which, yeah, so those are some of the suggestions.
Okay, so what did you adjust the numbers to? Did you guys adjust anything at your reception center? Okay.
We did. So the operational shift length was 12 hours.
Okay.
The shift, or the population arriving, was 2,500 still. The percent of population assumed contaminated was 25%, so that we would send messages back to the attendees of the baseball game. And then you guys are going to have to help me remember, Annie and Phil, if you want to use the message chat. I can't remember exactly. I know we upped the registration lanes at the end. I know we had multiple handheld detectors and portal monitors. Ginger, Phil, portals were 3. There you go. Number. Thank you, Phil. Handhelds were 4.
4, yeah.
Yeah. And then the showers, I think we left it at 2, right?
Yeah, and I think we put handheld detectors at 4.
Yeah. Yeah. Thank you, Ginger. Handhelds were 4. See, my group's chiming in. And then detectors post decon. Yeah, Ginger. Yeah, I'm thinking we did have the showers at 4.
Okay.
Yeah.
Did we add any registration?
I think we did right at the end. Annie, how many did we bump it up to? 15?
I think we had initially dropped it to 5 to push it back, or to restaff, assuming that we'd have a similar number of staff, and then we bumped it up to 10, and that did bring things down a bit. But so I think that's where we left it off.
Okay.
I think we borrowed people from our community, our neighboring community.
Okay. So we're gonna. Okay, so that is a good improvement, guys. Right, because we had to stay open 39 hours. So we've extended our shift by 4 hours. So, there's a little time there, but now we only have to stay open another 11. So that's great. We're processing a lot more people. That's great. We have just no waits or lines at the other stations. Registration is still, a bottleneck. So, but, that's usually the bottleneck for most things. But we've fixed a lot of these things, and the people that are contaminated are getting the decon they need. So this is great. I think you guys did a great job. Just a, fun fact about the tool, we designed it with these inputs in the right corner. That way, if you wanted to take a screenshot or snip this, then that way you could have it in any briefing for talking to decision makers. So that way, if someone's like, we need to get 40 portal monitors, you're like, listen, you really don't. I need 40 human beings to help me with this registration. So this is kind of the idea. And I don't know if anyone played with the tooltips, but if you're ever, unsure of how things are supposed to be used or work in the tool, everything has a tooltip and most things have a hover over. Okay, so Jim, do you want to let them know what our group did? I'm going to reset. You might need to unmute. I'm not sure. Yes, clean people at registration is a lot better than contaminated people at the port. I agree with you. Okay. Did Jim go away? He might be muted. I'm going to ask him to unmute. There we go.
Okay, I'm here.
Great.
Yeah. We took a slightly different approach. We decided to try to divide and conquer. After we looked at all the scenarios with maxing out the number of resources that were available, we still had unacceptable levels of performance. So we opened a second CRC, which dropped the number of people arriving at one of them. It should have been 1,250, but 1,000 was as close as we could come. And that improved things quite a bit. But in order to take it down further, we sent out emergency alerts to people before they got to the CRC, suggesting that they do some personal decon before they come to the CRC, whether that's, washing hands, face, shedding outside layers of clothing, etc. So we could decrease that from 50% contaminated upon arrival down to 25%. Then we left the number of portal monitors at 3. Well, 2 or 3 I don't think made much difference. Handheld decons before, we maxed that out to 4. Post decon, or the showers, we maxed out to 4. Post decon, handhelds at 4. And we upped the registration lanes to 15. So we need slightly more staff at each one of the centers, but as a result, we can process people a whole lot faster than we had before.
So yeah, I also think this was a great way to accomplish the task of solving the problem CRC I gave everyone. So here you have 20 minutes staying open past the shift. So we had 980 people of the 1,000 processed, and you can assume the other CRCs probably set up similarly. And then just there aren't any waits really, and then the line length is really low. So I think that, both options were really good. Both got the time open to be much less. So I think that, hopefully this shows that it depends on what's best for you in your jurisdiction, and you can kind of decide what's going to help you most. So thank you, Jim, by the way. Okay, so did anyone else have any, thoughts, ideas, things that, it was really obvious using the tool that was a bad idea to do? Sometimes it's nice to have definite no's. You can always type in the chat too if you have any audio issues. That was fun. You saw, okay, great. Okay, so I think I'm going to go back to the slides quickly and get some feedback. I think we're going to follow up with you after this, but kind of some things to keep in mind since we have, a couple minutes. You can type in the chat or, unmute, but, what did you like about the workshop? What could be improved? How did you like the tool? Is there anything that you would like added or changed to the next version? So Jim said he wanted a little more flexibility with some of the inputs. So that's definitely something we're looking at adding. Do you think you would use this tool in an upcoming exercise? Do you feel more comfortable using it? So kind of, keep this in mind. And we are trying to make this the most user-friendly tool possible. So all feedback, we want to know how to make it better. And if there was something you really liked, we want to know too, because if you like it, we really don't want to change it. People sometimes their favorite thing about something will go away and they're like, oh no, maybe more parameters. Okay. Oh, for the scenario. Yeah. Okay. That's a good idea. So and another thing about kind of the scenario at this workshop, we're hoping to kind of build in some type of documentation so that you could take it back to your state or local jurisdiction, and then you could use this to actually do this workshop with other people there. That way more people can use the tool and build it into your plans. Let's see. Nurses, triage, okay, in case someone's injured. It's a good idea.
Just as a quick reminder, in order to unmute yourself, just click the unmute button next to your name or dial *6 if you're calling in over the phone.
And again, this is the website. Also, if you liked, what we did today and you wanted to kind of take it back and share with others, then you can let us know, and then we can think about trying to figure it out for hosting in different locations. Well, virtually. I think it worked pretty well virtually. So that's something that we could do as well. Oh, great. That's great, Ginger. Awesome. I'm glad you plan to use the tool. Okay. So, and let me know how it goes. If you ever are, doing a training with the tool and there's a lot of questions or something's not understood, let us know, and then we can kind of go back and evaluate it. Okay. Well, let me stop sharing. Okay. So, Annie, did you want to follow up with anything else?
Yeah, just one final point for you all. I placed a link to our evaluation for this workshop in the chat, if you wouldn't mind filling that out. We'll also be following up with you via email, but please do take that out or take a minute to fill that out so we can gather your feedback. We'd like to continue hosting webinars for the NARR, and your feedback will help us continue to improve. So I think that's it for me.
All right.
Gina?
Yeah, thank you so much, everybody, for joining. I hope that you did find it useful. I found it pretty fascinating to see how the numbers would change the output, and especially as a planning tool, and figure out how many people you can get through the door versus how many you need to. And maybe it's going to end up being more than what you thought. So it's good stuff. And I hope that you all enjoyed the evaluation. I promise you is very short. If you wouldn't mind taking it, it just helps us along the way for future planning as well. So thank you, everyone. Enjoy your afternoon. If you have any questions, just follow up, and we'll be looking forward to hearing from you and seeing you again soon. Thanks, everybody.
Thank you very much.
Bye. Thank you.